Aortic stenosis is characterized by obstruction of left ventricular outflow resulting in decrease in the cardiac output. Obstruction of left ventricular outflow resulting in decreased cardiac output. That is, the aortic valve gets stenosed and prevents the blood from going out. That is, the aortic valve gets stenosed and prevents the blood from going out. It can be mild to moderate and is usually asymptomatic. It is important to monitor stenosis in the aorta. As we know, there are four heart valves. They are mitral valve, tricuspid valve, pulmonary valve and aortic valve. Out of which only the mitral valve has two leaflets and the rest of the valves have three leaflets. Hence, mitral valve is also called as bicuspid valve. Now, this is what a aortic valve looks like normally when it's open and when it is closed. And on the other hand, we can see what a stenosed aortic valve will look like when it is open and when it is closed. Clearly, the heart with a stenosed valve doesn't pump the blood efficiently. Even when the aortic valve is open, the stenosis results in a decreased blood flow. Even when the aortic valve is open, the stenosis results in a decreased blood flow. With the decrease in the blood flow, there is decreased cardiac output. Because of these following, three cardinal signs and symptoms of aortic stenosis are seen. They are exertional syncope or exertional dizziness, exertional dyspnea, and exertional angina. On examination, we can feel a slow rate of rise in the carotid artery, which can be felt around the neck. On examination, we can feel a slow rate of rise in the carotid artery, which can be felt around the neck. Normally, the carotid pulse rises fast, but in aortic stenosis, the carotid pulse is slow and weak. I'll repeat that again. Normally, the carotid pulse rises fast, but in aortic stenosis, the carotid pulse is slow and weak. On auscultation of the right second intercostal space, we have reduced intensity of second heart sound. Which is the sound when the aortic and pulmonary valves close. We normally have two heart sounds which are generally heard in a stethoscope, S1 and S2. S1 is heard when the AV valves are closed. S2 is heard when the aortic and pulmonary valves are closed. We are here listening to the right second intercostal space murmur in aortic stenosis. Before that, we will look at the normal thing. We have a first heart sound and a second heart sound. Joining these heart sounds, we can divide it into three things. The first one is the S1, when the AV valves are closed. When the AV valves are closed, the blood is in the ventricles. The ventricles begin to contract. The second is between the S1 and S2. Here, the ventricles are contracting so hard that it pushes the blood through the aortic valve. In S2, the aortic valve closes again, allowing the ventricles to fill back with blood. In S2, the aortic valve closes again, allowing the ventricles to fill back with blood. Thus, we can say between S1 and S2 is the systole. From S2 to S1 again is the diastole, when the ventricles are relaxed and filled back with blood. Between S1 and S2 there is systole, and from S2 to S1 is diastole, when the ventricles are relaxed and filled with blood. In aortic stenosis, the murmur we hear begins at S1. When AV valves close, Then we hear the aortic valve open. Then the blood is being squeezed through the aortic valve slowly. Thus we get a greater turbulent flow until the ventricles relax again and the aortic valve closes. I'll repeat that again. In aortic stenosis, the murmur we hear begins at S1 when the AV valves close. That is when the ventricles begin to contract. Then we hear the aortic valve open because the aortic valve has to open so as to push the blood into the aorta. Then the blood is being squeezed through the aortic valve slowly. Thus we get a greater turbulent flow until the ventricles relax again and the aortic valve closes, meaning the aortic valve is stenosed, right? So whenever it is opened slightly. So when the blood goes from the aortic valve, it goes slowly as if in a squeezing motion with a greater turbulent flow. This turbulent flow decreases when the ventricles relax again and thus when the aortic valve closes again. We call the aortic stenosis murmur a systolic click crescendo decrescendo murmur or ejection systolic murmur. We call this aortic stenosis murmur a systolic click crescendo decrescendo murmur or ejection systolic murmur. Now let's see again what happens in an aortic stenosis patient. The AV valve closes first. Ejection click as the aortic valve opens is heard. Then there is turbulence through the aortic valve which is increased and then decreased, and then the aortic valve closes finally. It is important to know that this murmur can radiate to the carotids. There are three major etiologies of aortic stenosis. First one is the congenital abnormal valve, that is a unicuspid or a bicuspid aortic valve. Remember, aortic valve is generally tricuspid with three leaflets. Second is the calcification of the tricuspid valve with age. Third one is the rheumatoid valvular disease. A rheumatic valve forms scar tissue leading to stenosis. Investigations include ECG, which shows left ventricular hypertrophy. Cardiac catheterization can be performed through the femoral artery or radial artery where the catheter is fed through till it reaches the aortic valve. The catheter allows visualization of aortic valve. Transthoracic echocardiogram. Transthoracic echocardiogram can also be performed and is gold standard for looking at valvular heart diseases. It is a gold standard for looking at valvular heart diseases. Management of aortic stenosis includes surgical valve replacement or repair. A valve replacement can be mechanical or bioprosthetic. Mechanical valve replacement is generally done for young people because it lasts longer. Use of long-term anticoagulants and antibiotics may be necessary for surgeries in those who are susceptible to infections and other. For a patient who is unable to undergo valve replacement, there is balloon valvuloplasty, where the valve's foramen is dilated, and transcatheter valve replacement can also be performed following a balloon valvuloplasty. Now let's talk about the opposite of aortic stenosis, that is aortic regurgitation. Here, the aortic valve doesn't close properly and comes back flopping into the left ventricle. Here, the aortic valve doesn't close properly and comes back flopping into the left ventricle. Normally, the flow of blood will be from left atrium to the left ventricle, then the aorta, then to the rest of the body. But in aortic regurgitation, the blood is coming back from the aorta into the left ventricle through the regurgitant aortic valve. Let's talk about the etiology of aortic regurgitation. When you get a widening or aneurysmal change, that means ballooning or outpouching of the vessel of the aortic annulus. the valve area becomes widened and the valve can't close properly. So this happens in conditions such as tertiary syphilis, some connective tissue disorders like Marfan's syndrome or Ehlers-Danlos syndrome. Another reason this aortic regurgitation can occur is due to infective endocarditis. In endocarditis, there is infection of the valve which results in formation of vegetation and a big ball of platelets and bacteria that can stop the valve from closing effectively. In endocarditis, there is infection of the valve which results in formation of vegetations and a big ball of platelets and bacteria. This stops the valve from closing effectively. And finally, rheumatic fever. And as we already know, the rheumatic fever affects the mitral valve, but it can also easily affect the aortic valve. Let's talk about some signs and symptoms of aortic regurgitation. Patients may experience fatigue. This is because all the blood that is pumped out into the aorta is not exactly staying there. Some of it may come back into the heart. This is why the patient experiences fatigue. Patient may also have syncope for the similar reasons explained above. Patient also has shortness of breath and palpitations are also seen. Other things you may want to look for while physical examination is wide pulse pressure. What is pulse pressure? It is the difference between the systolic blood pressure and the diastolic blood pressure. That is, pulse pressure is difference between systolic blood pressure and diastolic blood pressure. When the aortic valve opens, the blood comes through into the aorta with a pressure. This is systolic blood pressure. It is about 120 mm of mercury. Now, when the heart relaxes and the valve closes, because of the elastic recoil of the aorta, the pressure in the aorta is high, about 80 mm of mercury. This is diastolic blood pressure. And thus, a normal systole over diastolic blood pressure would be 120 to 80 mm of mercury. I'll explain that again. When the aortic valve opens, blood comes through into the aorta with a pressure. This is systolic blood pressure. It is about 120 mm of Hg. Now, when the heart relaxes and the valve closes, because of the elastic recoil of the aorta, the pressure in the aorta is high, about 80 mm of mercury. This is diastolic blood pressure, and thus a normal systolic over diastolic blood pressure will be 120 by 80 mm of mercury. Now, if this aortic valve was regurgitant, this is not normal. Now this is regurgitant and allowed blood back through into the left ventricle, you wouldn't be able to maintain that normal pressure of about 80 mm of Hg, which was due to the elasticity and recoil of the aorta on a closed aortic valve. But now you would have a pressure of around 50 mm of Hg because the valve is regurgitant. The blood is not staying there. Okay, the blood is not staying there. The blood is flowing backwards into the left ventricle. So the pressure decreases to about 50 mm of Hg because the blood will be flowing back through the aortic valve. In addition, as the blood is flowing back into the left ventricle, this actually increases the preload. What is preload? The preload means how much blood the ventricle is filled with. And due to something like Frank-Starling's law, if you have increased preload, the heart contracts harder and better to put out all the blood that is received, so that the systolic blood pressure will actually increase. So if there is an increase in the preload, you no longer have the systolic blood pressure of 120 mm of mercury because it will be increased to around 140 mm of mercury. So if there is an increase in the preload, you no longer have the systolic blood pressure of 120 mm of Hg because it will be increased to around 140 mm of Hg. So now you go from a pressure of 120 by 80 to 140 by 50 mm of Hg, which is going to increase the pulse pressure. What is pulse pressure? Difference between systolic blood pressure and diastolic blood pressure. So thus there is increase in the pulse pressure. Another thing you may notice on physical examination is left ventricular dilatation. On auscultation, an aortic regurgitation can be heard as an early diastolic murmur. On auscultation, an aortic regurgitation can be heard as an early diastolic murmur at the left sternal border. This is called as an Austin-Flint's murmur. Now let's see some signs associated with aortic regurgitation. First one is the main sign. It is the fall in diastolic blood pressure when the arms are raised above head. It is the fall in diastolic blood pressure when the arms are raised above head. Second one is Dubrowski's sign. Systolic and diastolic murmur heard over femoral artery. In Dubrowski's sign, there is systolic and diastolic murmur heard over femoral artery. Vessels are compressed with the diaphragm of stethoscope. That's why there is systolic and diastolic murmur heard over femoral artery. Third one is the Corrigan's sign. Because of the left ventricular hypertrophy, it sends blood with full force. Heart sends blood with full force, which results in prominent carotid pulsations. Demusset's sign. Demusset's sign is characterized by head nodding in time with heartbeat. As the heart beats, the person nods his head. Next is Hill's sign. In Hill's sign, there is higher BP in legs than in arms. Next is Quincke's sign. In Quincke's sign, there are pulsatile capillary nail beds. Now let's see the management of aortic regurgitation. Management includes aortic valve replacement. In which patient should we replace aortic valve? Patients who have symptomatic severe aortic regurgitation, the aortic valve needs to be replaced. In patients who are asymptomatic with ejection flow less than 50%. Or in patients undergoing any other cardiac surgeries. Suppose a person is undergoing a bypass surgery and the person is also suffering from aortic regurgitation. You can replace a valve in the patient undergoing bypass surgery. Thank you.